Hi everyone, my name is Maimuna Chaudhry, and today I'll be presenting my health education intervention focused on increasing preventative healthcare knowledge among low to middle class bilingual South Asian females ages 18 to 21 living in Piscataway, New Jersey. I know that's a mouthful, but we're going to get into it and break it down. But just for some context, this age group has both high insurance coverage and high linguistic diversity, but they continue to face gaps in health literacy and access. My intervention is grounded in community needs and culturally responsive strategies, aiming to bridge those gaps through education, navigation support, and peer-led engagement. Taking a look at my population and community, the project focuses on bilingual and South Asian females ages 18 to 21 who live in Piscataway. Many come from households where languages like Urdu, Hindi, Gujarati, Punjabi, or Bengali are spoken at home. Although insurance coverage is high in this population, with over 95% of women living in Piscataway being insured, language barriers and a lack of knowledge about what insurance actually covers prevents them from fully utilizing these preventative services. The township itself has a large, well-established South Asian population, which is important because it creates cultural familiarity, strong family networks, and community institutions that we can leverage for health education. But that same cultural context can also introduce hesitation, stigma, and reliance on family decision making when it comes to healthcare. Taking a look at the environment, Piscataway is a suburban township with a lot of geographic and institutional assets such as Rutgers University, as well as the proximity to two major regional hospitals in the nearby New Brunswick area, including the Robert Wood Johnson University Hospital, as well as St. Peter's. There's also libraries and the YMCA Community Center. At the same time, the township's built environment includes a mix of residential areas, cultural centers, and religious institutions. These spaces are not just physical locations, they're key gathering points for South Asian families. Because the community is so culturally dense and diverse, health programming must be tailored and delivered in familiar, trusted spaces. And this is why my intervention intentionally uses community locations like the YMCA, local mosques, and libraries. Taking a look at the health issue of preventative care. Preventative care is underutilized among Asian American groups, especially those with limited English proficiency. Research shows that factors like nativity, language, and knowledge gaps impact how often individuals receive screenings, vaccinations, and annual checkups. Preventative care lowers long-term health risks and healthcare costs, and Healthy People 2030 emphasizes increasing evidence-based preventative visits as a national priority. For this age group, establishing healthy habits early is important because young adults often only go to the doctor when they're sick, not for prevention purposes. Taking a look at key researchers, these are three researchers whose work helped guide my intervention design. We're starting off with Dr. Seong Park, who studies disparities in preventative services among Asian Americans, particularly how English proficiency affects access for these Asian Americans. Dr. Samantha Harris focuses on adolescent and young adult preventative care and how outreach and reminders improve engagement. And Dr. Neetu Sharma researches community health worker involvement, which informed the peer navigator component of my intervention. Their work highlights the importance of culturally tailored, linguistically accessible education, exactly what this project uses. Taking a look at my intervention approach, my intervention is called Saki Health Navigators, Saki meaning female friend in many South Asian languages. This model uses bilingual peer navigators to educate participants in a culturally comfortable environment, and it focuses on having three pillars. The first one being peer-led workshops, providing preventative care education. The second one being navigation support, which is helping participants schedule appointments, understand insurance, and find providers. And the third one being digital reminders delivered on platforms this community actually uses, including Instagram and WhatsApp. This approach is rooted in research showing that community health workers and peer-led models increase preventative care uptake in minority communities. When we focus on intervention benefits, we can find that this intervention offers three main benefits. It increases health literacy by breaking down what preventative care is, why it matters, and what their insurance covers. It reduces culture and language barriers, which are some of the biggest obstacles South Asian women are facing. And it builds long-term habits, encouraging routine checkups, normalizing preventative visits at a young age. Because this program is culturally grounded and peer-led, participants are more likely to trust the information and apply it. Taking a look at the evidence that bases all this work, evidence strongly supports the evidence strongly supports this type of multi-component intervention because peer educators and community health workers significantly improve preventative service uptake, especially in immigrant communities. The multi-component interventions, such as those combining education, reminders, and navigation, are more effective than single strategy programs, and digital reminders have been shown to increase appointment follow-through, especially for young adults who heavily rely on their phones. And these findings validate each component of the Saki Health Navigators program. When we take a closer look at marketing and outreach for this initiative, marketing must be culturally relevant and meet young adults where they already are. For this population, Instagram and WhatsApp are primary communication channels. WhatsApp especially is being used in South Asian homes. Community partners are essential, such as mosques, student organizations, and community centers that offer the built-in trust and audience reach that we are looking for. We also use peer ambassadors and small incentives like gift cards, which research shows improve participation in preventative health programs. For the evaluation plan, to evaluate this intervention, I used a mixed methods model, so meaning we'll do pre and post surveys to measure changes in knowledge and confidence in navigating the health system. We'll do a 30-day follow-up to see who actually completed a prevention action, like getting vaccinated or scheduling a checkup. Then the third will be tracking attendance and digital engagement, which helps measure reach and consistency. The program aims for a 25% success rate, meaning 1 in 4 participants completes a preventative health service after the intervention. If we're focusing on appropriate upstream interventions address the structural barriers before someone even reaches the healthcare system. For this population, statewide access to translation services and broader health literacy initiatives would drastically reduce disparities. Even if someone has insurance, if they don't understand how to use it or communicate with their providers, they won't get that preventative care. Upstream changes ensure that what we do at a community level has a stronger foundation. Impossible changes. If I were to change one thing about my intervention, I would include parents much earlier on. In South Asian households, parents strongly influence young adults' health decisions and their perceptions of the healthcare system. Involving them could reinforce the importance of preventative healthcare and reduce hesitation or stigma. Parent involvement would also strengthen the long-term sustainability of the intervention. My role as a health educator. So in this project, my role as a health educator was to assess the community's needs using demographic, environmental, and behavioral data. I identify barriers such as language, culture, and health literacy gaps, as well as develop a culturally relevant, evidence-based intervention aligned with public health frameworks like the health belief model and the Bloom's taxonomy. This project really reflects the processes of what health educators are truly trained to do. And taking a look at some of my reflections upon completing this project. So I do feel like I gained expertise in this community and issue. Completing the HERP stages required deep research into the community characteristics, the environment, and the health behaviors of South Asian young women in Piscataway. And living near records and interacting with peers who fit this demographic also gave me firsthand insight. But expertise is always evolving, as we know it. So health literacy and preventative care are areas where continuing education will always be necessary. And now that this project is complete, I plan to use it as a foundation for real community health work in the future, a writing sample for professional and academic opportunities, and a model for designing future health education programs. This project really helped build skills that I can take into my future career in public health, especially in community engagement and culturally responsive programming. Thank you very much, and it's been a wonderful semester.